in the cold day. I'm Wayne Simmons, and I would like to welcome you all to the endoscopy session on the Wednesday afternoon, the iEcho session. The iEcho is hosted by the Gastro Foundation in association with Project ECHO, University of New Mexico. And these sessions are held weekly on a Wednesday. We found them very beneficial and helpful, and it's a pleasure to be here to talk today. The chat box will be open for questions. So if anyone has any burning issues or questions through the talks, please add them to the chat and we'll be glad to address them throughout the talk. It gives me great pleasure to introduce the topic. We'd like to touch on the topic of common ano-rectal conditions today. And it's my pleasure to invite and introduce Dr. Rahm Makan, who's a colleague of mine from the Free State. And before he starts, I'd just like to take the opportunity to congratulate him together with the colleagues that he wrote with for the college exams. As far as I'm aware, they've all passed well, and we'd like to wish him well and say congratulations on this platform as well. Well done, Rahm, and well wishes for the road ahead. With that, I'm going to hand over to you to kick off the discussion with an overview on the discussion or on the topic of common anorectal conditions. Thank you.
Well, thank you very much for the welcome and introduction. Okay, so we're going to look at common anal pathology that we see. This is basically a revision set of slides just to look at what we see. So looking at just to familiarize ourselves with the normal anatomy, just to remember, we have the internal sphincter and the external sphincter, which is under voluntary control. And then we have the normal anatomy of the external hemorrhoidal plexus and then the internal hemorrhoidal plexus. Then we also have the anal glands, which are responsible for mucus secretion. And then those glands are then connected to external opening crypts. And then we have the dentate line as well. And then we have the columns of Morgagni as well. So hemorrhoids, very commonly seen. It's a normal part of the anatomy. It's the venous plexus between the mucosa and the internal sphincter. And these plexi assist with continence, particularly for liquid stool and flatus. Then we look at the grading of hemorrhoids. We see grade 1 is where you just have mild enlargement of the internal plexus. They may push into the canal, but they do not prolapse. With grade 2 hemorrhoids, they can prolapse, but they retract spontaneously. With grade 3 hemorrhoids, they prolapse while passing stool, but require manual reduction. And then grade 4 hemorrhoids cannot be reduced. So internal hemorrhoids has been believed to have been caused by loss of connective tissue. And then that loss then causes the remaining tissue to then protrude into the anal cavity. The symptoms patients typically present with is painless bleeding. They may complain of dripping of blood and bright red blood. This is managed typically where you encourage the patient to increase their water intake. You want to encourage a high soluble fiber diet. You want to give the patient stool softness to prevent hard stool that would worsen this pathology. And ultimately, you can then perform procedures such as band ligation, sclerotherapy, or cryotherapy on these hemorrhoids. Once the hemorrhoids reach grade 3, surgical therapy such as hemorrhoidectomy is suggested. This is an image of a thrombosed external hemorrhoid. So if you look at external hemorrhoids, they're usually visible at the anal verge, like in the image just seen. These are typically redundant skin from previous inflammation, and that then results in edema and thrombosis of the vein. The thrombosed external hemorrhoids are the most painful type. Typically, these hemorrhoids are treated with excision. An important point to remember is that patients with Crohn's disease may present with what may look like an hemorrhoid. And these are external skin tags that are waxy and bluish that may look like this. Some people refer to them as elephant ears. So one must be careful not to misinterpret these as external hemorrhoids. Looking at the next type of pathology, we see an anal fissure. So an anal fissure is a linear tear of the anoderm, typically in the posterolateral aspect of the anus. And it's typically brought about by passing a large, hard stool. It can be seen after vaginal delivery. And the hypothesis behind this is that it's due to a reduced blood supply to the posterior midline and the elevating resting anal pressures with the hard stool then results in a lack of blood supply to the tissue and leads to tissue loss and the fissure formation. These patients typically complain of very severe pain. The treatment for this, one would increase the water intake, soluble fiber, stool softeners to ensure soft stool. Bran fiber has also been shown to be beneficial, sit spots as well to allow for hygiene. So because we believe that it's due to a reduced blood supply, topical nitroglycerin, calcium channel blockers, glyceryl trinitrate ointments, diltiazem ointments have been used for therapy. These are all vasoactive substances. If it's very severe, one may consider a reversible chemical sphincterotomy with botulism to reduce spasm of the sphincter. And if that still doesn't work, one can consider surgical therapy where one may perform a lateral internal sphincterotomy. However, the risk of incontinence then increases. If you look at the next pathology that we might see, it's abscesses and fistulae. One must be aware of the many causes such as cryptogranular infection, Crohn's disease, TB, actinomycosis, trauma, foreign bodies, previous anal surgery, a pilonidal sinus, hydronitis suppurativa, Bartholin's gland abscesses, carcinomas, and lymphomas. So usually if one sees an abscess or fistula, one needs to look for these pathologies to not miss it. There's four main types of abscesses. It's the perianal, ischio-rectal, intersphincteric, and supralevator. So here's a diagram showing each type. So you have the intersphincteric between the external and internal sphincter. Then we have a perianal abscess, more externally orientated. Then you have the intersphincteric abscess, ischio-rectal abscess, and then you get a supralevator abscess. The next common pathology is a fistula in ano, which is defined as a tunnel connecting the internal opening with the external opening. Three main types exist. It's intersphincteric, transsphincteric, and extrasphincteric. So here we can see the extrasphincteric, where it originates within the bowel and then travels beyond the sphincters and then exits. And then you get the transsphincteric type, which goes through the sphincters. And then you get the intersphincteric type. The treatment for fistulae is usually surgical, involving a fistulotomy, where the fistula is surgically laid open and allowed to granulate and heal. One may also consider using fibrin glues and curettage. A seton may be placed, and there's a lift procedure where the sphincter is disrupted in its course, and the proximal side of the fistula is then sutured closed. Here's an example of a seton that has been placed that then allows the fistula's tract to be slowly brought outwards towards the skin. The other common pathology seen is anal malignancies. So this incidence has increased in HIV-positive patients where the risk increases 12-fold just by having HIV alone, whether it's controlled HIV or uncontrolled HIV. And the type of carcinoma that is seen is typically squamous cell carcinoma, which counts for 80% of the cases. And of those 80%, 86% of those are HPV related. Adenocarcinoma then accounts for 5 to 19% of the remaining, melanomas for 1%, and Paget's disease for the remaining 1%. Pre-malignant conditions also are HPV related. They classified into low-grade squamous epithelial lesions and high-grade squamous epithelial lesions. Anal warts are also seen as a pre-malignant condition, and they're also HPV related, and the types are 6 and 11. The treatment for these anal warts typically involve podophyllin cream, cryotherapy, trichloroacetic acid, 5-fluorouracil creams, imiquimod cream, and catechins, a green tea extract, has also been shown to work in 50% of patients that tried it. Anal stenosis is also quite common pathology, and usually it's after a surgical procedure, and that most common surgical procedure would be a hemorrhoidectomy. The treatment for that would be stool softeners to increase the water intake, soluble fiber, and then one may also use mechanical dilatation as required. If one looks at functional rectal pain syndromes, there is proctalgia fugax, where one may have a normal endoscopic finding. However, the patient then would complain of recurrent episodes of rectal pain localized to the anus or lower rectum. These episodes last for seconds to minutes. They do not have pain between episodes, and it may awaken the patient from sleep. These patients may find relief from walking, soaking in a tub, and bowel movements. It's postulated due to anal smooth muscle dysfunction that may be triggered by stressful events or emotions. So these attacks usually are very transient, and they resolve before treatment can be initiated. However, the treatment that is suggested is nitroglycerin topical ointments, inhale salbutamol as well, and in very severe cases, one may consider botulinism or a pudendal nerve block. The other functional rectal pain syndrome is levator-ani syndrome, characterized by the Rahm 4 as chronic or ongoing pain or aching in the rectal area. The difference is these episodes last for 20 minutes or longer, and a digital rectal exam confirms levator tenderness. So if one does not find levator tenderness on rectal examination, that makes the diagnosis very much less likely. This typically affects women of younger age, younger than 45 years old. And it's described as vague tenderness high up in the rectum, the feeling of a rod inserted into the rectum. However, it does not wake these patients from sleep. Suggested treatments for this levator-ani syndrome include salbutamol inhalers, diltiazem creams, clonidine, amitriptyline, electrical stimulation, a levator massage, and biofeedback therapy. These are my references, and thank you for listening.
Thank you very much, Ram. Just before we move on, I don't see any questions on the chat. If anyone has any questions for Ram at this stage. I don't see any hands or any questions on the chat yet.
Hi, can I ask?
Yes, Siabi, welcome.
Thank you, Ram. So often with patients with anal fissures, as during part of our trainings, we were told the patients can be given, the nitroglycerin, which they're supposed to crush and mix it with Remicade jelly and then apply it. But is there an actual recommendation as to the dosage? Must they crush 2 tablets? Must they crush 4 tablets? Is there an actual recommendation with regards to the dosage of the nitroglycerin that they're supposed to get?
So I think it's just a standard tablet that they use for it's easily available that we use for the cardiac patients. So they should crush. So they shouldn't crush it and store it, because then the tablet might lose effect. So I would suggest them crushing at least 2 tablets with the mixture of the jelly, and then using it as needed. So if I'm not mistaken, it's 10 milligrams per tablet, so it'll be 20 milligrams, and they can use it as required thereafter. Is that in keeping with what you suggest?
So, I mean, we have the 20 milligram, I think they give them ISMO, but then it will also have the same issues with, orally taken ISMO with the headaches and the hypotension. So patients still have to take the same precautions that they do with ISMO that's taken, or another glycerol trinitrate, which is taken orally. They say it's supposed to improve, so it causes like vasodilatation in the perianal area, which is supposed to then somehow improve blood flow and promote healing. So it doesn't actually directly heal by itself, but it works by improving blood flow in that area, which then helps the patient heal quicker.
Thank you, Dr. Shelby. So I also have it as 20 milligrams, and yeah, so the absorption from the rectal mucosa or anal mucosa is quite with the lower venous drainage, systemic drainage, is quite similar. So the systemic effects are definitely, as you've mentioned, and should be counseled. These patients should be counseled. I'm not aware that there's any benefit to use more than 20 milligrams. Yeah.
And then also with the, I think you mentioned the intraepithelial neoplasia or squamous neoplasia in patients. So anal intraepithelial neoplasia. So patients have to have what they call it high resolution anoscopy, which to me just looks like, you put a cap at the tip of your scope, but then you use dye, maybe like Lugol's iodine, to better enhance the area, because I don't think a lot of us have anoscopes, but we recently had a presentation in our unit, and I think it's something that can be done with a normal scope, but you just have to use like dichromendoscopy and really look at that area for subtle lesions which might progress to high-grade dysplasia. I think we've treated one patient with we gave her topical 5FU, but we had actually resected that dysplastic segment, and on a repeat biopsy of the scar, there was no evidence of dysplasia. So I'm not sure if it was actually eradicated, but for now, the patient remains under follow-up. But it's a condition that we as gastroenterologists don't really look for. That area is not very well inspected. And yeah, thanks for doing this presentation and raising awareness.
So I think we also use the acetic acid as well, as we would do for the esophagus.
Yes,
and then
that as well.
Look for the areas that are, appear dysplastic, and then perform targeted biopsies on those areas.
Thank you very much. So I think surveillance of these areas and thinking about the condition, I think when we started discussing this topic, it's actually what sparked the discussion, in that we talked about anal papilloma, and in that whole realm of these HPV-related or stimulated conditions, and these intraepithelial lesions are definitely things that we possibly are missing, but one should just have a high index of suspicion for them. I saw a hand first, Dr. Ramanati.
Oh, hi, everybody. No, thanks. Actually, I pressed by mistake there.
Thank you. Thank you. See, there's a question here from Badruddin Yusuf. Any role to survey patients with long-standing perianal Crohn's disease for anal squamous cell carcinoma? I'm not aware, but I don't think that there would be in Crohn's disease that we would do a different surveillance for anal squamous cell carcinoma as we would for your normal IBD surveillance, as with Crohn's. So that would mirror that surveillance as far as I understand. But I think the meticulousness in the rectum, as we've just discussed, would be paramount. I don't know if anyone else has any other suggestions or points. Rahm?
I think this patient would be surveyed on the basis of the inflammatory bowel disease. So one would be surveying that area regardless. So I don't think that it would be a separate, screening program for that. Thanks.
Thanks. I don't see any more questions, so I'm going to thanks again, Rahm, for that overview. I'm going to share my screen. And then to talk about the clinical case. And I think it ties in nicely with what we've talked about and the whole idea about having this index of suspicion in the rectum, anorectum. So my case is one of a 59-year-old obese man with metabolic syndrome. He's got ischemic heart disease and obstructive sleep apnea on CPAP therapy. He complained to his local surgeon about episodic blood per rectum and was found to have refractory iron deficiency anemia. He presented with a hemoglobin of 9.1 grams per deciliter. His ferritin was 33 nanograms per mole and a transferrin saturation of 4%, so properly iron deficient. He declared being a Jehovah's Witness, and throughout the interaction with him, he expressed that the idea that he would not be or accept blood transfusion for the treatment of his anemia. We emphasized that the focus would be iron replacement in his case. But definitely, the further management, in the surgeon's mind was he had a bit of an awareness of the patient's background. The surgeon did an upper endoscopy, which was found to be normal, and he went on to do a lower endoscopy where he noted a few left-sided diverticuli without any sign of bleeding. He then presented the patient as a patient with obscure GIT bleeding, and in this case, we viewed it as occult. But the patient continued then in the follow-up after his initial scopes to complain of this episodic blood per rectum, especially where he was more constipated. And he had attempted oral iron therapy in replacement or repletion, and the HB actually wasn't responding. So the surgeon referred him, and the initial thought was to do a re-look lower endoscopy because there was some question about the preparation of the primary lower endoscopy. So I did the lower endoscopy, and initially I did not find anything more than what the surgeon found. But for some reason, in this case, I elected to do retroflexion in the rectum at the end of the colonoscopy. And I was very alarmed to find this lesion just above the inferior valve in the rectum. So with this surprise, we decided that in talking about the patient, we decided that we're not going to primarily do polypectomy for this lesion. And with the patient's low hemoglobin, that we elected that we would postpone the procedure. This was a Paris 1 SP polyp, and looking at the NICE criteria, it was graded 2. So we were worried about the probability of it being adenomatous. And as I've said, it was just above the inferior rectal valve. So this brings us to what I'd like to just shortly discuss, and that's the topic of rectal retroflexion. It's something that we've discussed of late, and there was a lot of question as to whether, is it something that we should be doing all the time? I know we certainly, in teaching, in training, we emphasize that it should always be done. There are some people who are proponents of it being done in the beginning of your procedure when the sedation of the patient is maximal and that the discomfort is less. There are others who feel that it should be done at the end, a good inspection on front viewing with the endoscope. So I'd hope to dispel some of the issues with regards to rectal retroflexion and just look at the entity again. So I think Rahm talked about the ano-rectal anatomy, and I think, like in this patient's case, when you are passing an endoscope through the anoderm, the anal sphincter, internal anal sphincter, external anal sphincter, passing through the anal verge. You can visualize the dentate line, but it's not difficult to miss pathology there. We do know that even on rectal examination, sinister lesions may not be felt. And on front viewing, it can be that very low down that lesions can be missed in the upper anus and just above the pectinate or dentate line. Getting to the valves of Houston, I think the case in point, when I checked with the surgeon again, he couldn't remember, it wasn't recorded that he did retroflex in the rectum. And, on retroflexion, this lesion was found just above the inferior rectal valve. And certainly on front viewing, I didn't see it either. So the procedure of rectal retroflexion, I think to go through it, it must be done with optimal bowel preparation. It's performed, as I've said, after initial examination in forward view. So it's very important to get a good view of the anorectum in forward view. It's also important for safety to determine that the caliber of the rectum is appropriate and, will be okay for the, in terms of size to accommodate the retroflexion. The endoscope is then repositioned or retracted to reposition at the anal verge, keeping the rectum inflated. And then the endoscope is then advanced while deflecting in a tip-up direction with the big wheel to the maximal extent, and at the same time rotating the endoscope counterclockwise to turn the scope around itself to look at itself. And I always find this 20 handy, the 20 centimeter marker handy as a successful retroflexion. From there, you can move further counterclockwise or clockwise to complete the visualization of the anal canal that's visible at the bottom, and then 3 to 4 centimeters of the rectal mucosa that is then visible on retroflexion. I think it's paramount that the bowel preparation, again, I emphasize, and with a clear preparation, photo documentation, as you would with other parts of the colon, is important. So what is important is to traverse these valves, because you may just on retroflexion look at the anal verge and the 3 to 4 centimeters, but where possible to just advance the scope further and make sure that you've had a good look on retroflexion behind each of these valves, like in our case now where there was a significant polyp there, which is the probable reason for the patient's bleeding in this case. So retroflexion is useful to visualize lesions missed on forward view, and these may be internal hemorrhoids or hemorrhoidal tags, inflammatory bowel disease of the anus or rectum, we've talked about that already, ulceration of any other cause, angioectasia, papillomas, rectal polyps, anorectal malignancies or neoplasia. And then once you have a pathology in the rectum, retroflexion is often important and often needed or required in intervention, either to biopsy a lesion, to manage bleeding, or then to do polypectomy, either by endoscopic mucosal resection or submucosal dissection, which is where EMR is preferred in the rectum. So retroflexion is a handy thing in intervention. But in looking at the literature, you find that in terms of visualizing lesions, the question is, does it really increase your polyp detection rate versus front viewing alone? And I looked at this study from Ramsey and his colleagues in 2001, and they looked at the utility of retroflexion in colonoscopy, and they had 600 patients. 30 anorectal lesions were found, with 50% found only on retroflexion. So they classified lesions into those found both on front viewing and retroflexion, and then they looked at lesions, or there were lesions that were found only on retroflexion. This was 50% of them. Of that 15 lesions, or of the 30 lesions, adenomatous polyps counted 9, and 6 of those 9 were found only on retroflexion. And what they also mentioned was that 50% of these retroflexion identified polyps had right-sided adenomas. So was definitely relevant in terms of the therapeutic interventions of these patients. And then they noted that there were no reported complications. Interestingly already is that none of these lesions that were found, that were retroflexion only identified, were found to be neoplastic. If I look at the study in the same year by Hansen, they looked at rectal retroflexion, an essential part of the lower gastrointestinal endoscopic examination. They had 526 patients that they did flexible sigmoidoscopy on, initially on front viewing. And then on the same patients, they evaluated them, made their comments on front viewing, and then they did retroflexion afterwards. The patients that got retroflexion were 480, and 17 of those patients that did not have retroflexion was due to discomfort. 12 patients with polyps were seen only on retroflexion, and that was 2.5% of the total. Of these 12, 8 were hyperplastic, 4 adenomatous. Importantly, there was no neoplastic lesions that were discovered only on retroflexion. And they felt that they increased their adenoma detection rate by approximately 1% by doing rectal retroflexion. So their closing comment was that this should be an integral part of flexible sigmoidoscopy. So this theme, if you look through the literature of the low yield of neoplasia for rectal retroflexion, continues, where Sard and Douglas Rex looked at this in 2008, and they looked at specifically the yield for neoplasia. So they did a prospective study on 1,502 patients. Again, they compared this front viewing versus retroflexion, and of those 1,500 patients, they could successfully retroflex in 1,411 of them. The comment why they couldn't retroflex in the 6.1% was the narrow rectum. Again, this idea of caliber, which should be emphasized. So you have to, on front viewing, determine whether you can retroflex on an estimation of the caliber of the rectum first. So these rectal polyps were detected in 40 patients. 33 of those 40 were visible both on front viewing and on retroflexion. Of that 33, 25 were hyperplastic and 8 were adenomatous. Again, no neoplasias. 7 of the 40 were visible only on retroflexion. Didn't clarify what was the nature of these lesions, but what was clear was that of this 40, there was no neoplastic lesion that was detected. So the summary point that I took from that article was that since retroflexion has risks and may cause discomfort, the use of routine retroflexion should be at the discretion of the endoscopist. Later, in 2014, Teles Avila and his colleagues looked at the diagnostic yield again and therapeutic impact of rectal retroflexion. This was a prospective study on 934 patients. They were able to do retroflexion successfully in 917 of them. They detected 32 patients with lesions. 22 of those 32 were both on front viewing and retroflexion, and 10 of them were only found on retroflexion. So that gives a figure of 1% of lesions that were found only on retroflexion that were missed on straight viewing. And all these lesions, again, had a therapeutic impact. So their comment in the end, and what I gleaned from them, was that rectal retroflexion has minimal diagnostic yield and therapeutic impact. However, they felt that its low rate of major complications and the possibility of detecting lesions justifies its use. Again, in this study, none of these lesions were found to be neoplastic. So really a very low yield of neoplastic lesions on rectal retroflexion. So all neoplastic lesions were found on front viewing, which is the common theme throughout these studies. The AGA emphasized this in 2013 as well, when this article then emphasized the low yield for neoplasia. And they said, while it should be done, it should be undertaken only once adequate luminal diameter or caliber is ascertained on front or forward viewing. So the same theme applied. The risks, so the AGA also talks about a 1.02 per 100,000 retroflections, resulting in a significant complication. And the ways to guard against complications in rectal retroflection, I think, is to insufflate the rectum appropriately or to the full extent, to initially do front viewing and inspect the forward view primarily to determine whether you feel that the caliber will be adequate for the retroflexion. And then in performance of the maneuver, there are three resistances that you may feel. It's when you are deflecting the tip with the big wheel. If you feel any resistance there, you should stop and reassess. If there's a resistance to forward advancement, and as you do your counterclockwise torque, if there's any resistance to that, you should stop. If there's patient discomfort, of course, that should also make you heed caution in rectal retroflexion. So back to our patient, we postponed the polypectomy of the patient, and I think we discussed it with him, and he was happy that we could postpone. It was certainly not an emergency. We had some query whether this polyp was really responsible for his iron deficiency, but the bleeding episodes that he reported were quite profuse and actually confirmed by his wife. So we didn't find any other lesion of the diverticulosis, left-sided diverticulosis, that could explain, long-standing blood loss to explain iron deficiency. But we elected to give him a full repletion dose of intravenous iron, and that worked quite well. In the 2 weeks to follow, his HB was 10.5, and 2 weeks to follow that, it was 11.9. This procedure was done in the middle of May, and he's just had some obligations. So we've booked him, our family obligation. So he's deferred the resection that we initially planned, and we have him booked for endoscopic mucosal resection. And this will be another place, I assume, where rectal retroflexion is likely to be employed, as we do the EMR in this case. I can't see that this lesion will be done on front viewing only. So emphasizing the point of retroflexion being handy for intervention in patients also. I must say, in our experience, or in my experience, if I look at the last 6 months of all the lower endoscopies that I've done, this is the one where I saw a lesion on retroflexion that I didn't see on forward viewing. So it's definitely something that is similar, or the similar experience as these studies that I've mentioned thus far. So in conclusion, I think rectal retroflexion is an important tool in anorectal evaluation during endoscopy. I think Dr. Makan has mentioned all the outward lesions of the anorectum, and I think to have an inner view is important. I think we've touched on the intraepithelial lesions, and I think the staining all on rectal retroflexion would be paramount in surveying these patients. I are not said, I think the studies emphasize low yield for detecting neoplasia in rectal retroflexion. So still maintains the standard, and I think for neoplasia detection, but we can't ignore the fact that in the rectum there are these areas that are not amenable to front view, like above the valve, so to speak. So good insufflation, retroflexion, and evaluation of all these hidden areas in the rectum is paramount. In doing so, you can rest assured that the risk of perforation and bleeding is low with this procedure, but it stands that we should be cautious, and any initial insufflation and inspection on the forward view to confirm the caliber. And then I've given you the instances where you should stop and reassess in form of resistance or discomfort that the patient might experience. And then it's not the case, but the question is, should the rate of rectal retroflexion and photo documentation on retroflexion be included as a colonoscopy quality indicator? I couldn't find information on this, and it's certainly something that one can think about. And I don't know if there are any comments or questions about that part, but this is just something short that we thought we'd want to impart, reflecting on rectal retroflexion. Thank you very much, and we open to questions further. I don't see any questions, Rahm. Any points from yourself?
I think you presented some people are for it, some people are against it. I would say it's something we can do. We already are doing the procedure, and I don't think we have much to lose to do it. And you may find that extra 1 or 2% of pathology, which can save the patient. So I would say it's worth to do it. Sometimes it might be difficult, but it's worth a try.
Certainly, I think as we are training everyone, as we've been practicing it, or it's part of the routine lower endoscopy for us, and I think the idea of doing it, I think, is important. I see there's a hand up by Dr. Ramanati again.
Oh, yes, good afternoon. Well done, guys. Thank you very much. According to the training that we had, that was around maybe 2014, 2016, the trainer course, which was given by, it was British Society of Gastroenterology. It was offered in there's Wolverhampton, I think. That's where we have deducted our training from, really. They really recommend, it's part of even like documenting that you're doing a proper endoscopy, basically, that you should retroflex. But then when they recommend that, it's just a recommendation that in the beginning, when the patient's still deep, it's assumed that in the beginning, the patient's still deep in the sedation, because it can be very uncomfortable. Because it is thought that by the time when you're towards the end of the procedure, the patient's almost waking up. But remember, for us as physicians, we don't use general anesthesia. I mean, so I think that's the consideration, that in the beginning, the patient is deep, then you can do that. Yeah, like I said, nothing has changed in terms of the teaching. Well, the arguments are there, but the teaching is still, that's what we're doing. We retroflex, but when usually in the beginning is better, I don't know, but that's what we're doing, really, based on that. Nothing has changed so far. Yeah, I'm not sure if there's any other different opinion.
Yeah, I agree with you. I think we're definitely doing it. And I think the idea is that even if you do it in the beginning, when the patient is heavily sedated, I think the emphasis that I got from reading through was that you should still have a good forward view look before, or you shouldn't automatically just go into retroflexion in the beginning. So still have a good forward look and then retract and come back and do your retroflexion. Any other comments from anyone?
I often find it's easier to perform it on withdrawal because there's usually already enough insufflation. In the beginning, the mucosa is all collapsed and compressed, and it is more difficult in the beginning. So I find it much easier on withdrawal to retroflex.
Yeah, I assume then it's each one to his own. I think each one will have their conveniences about how they're doing it. I don't see any more questions on the chat. If there are no more questions, I think we still have time, but I think we can call it a day. There's nothing more to present, and I think, let me just look through the chat again. I don't see anything.
Well done, guys. Thank you.
Okay. If there's no questions, that leaves me to Dr. Makan again for the initial talk. Thanks to the iEcho University of New Mexico and the iEcho India team. Just to note that all the recordings are available on the Gastro Foundation website. We'd like to thank the Gastro Foundation for the support here. Thanks, Dr. Makan, for presenting this. Thanks to the sponsors. And then next week, we will have the Wednesday discussion again. where the topic will be inflammatory bowel disease. So that's the end, and we'd like to wish everyone a good afternoon and see you next week. Thank you very much.